Excellent. If everybody could take a seat, we can start with the program. Good morning. My name is Humberto Mestre. I'm a fifth-year PhD student in the neuroscience program, and it is my pleasure to welcome you to University of Rochester School of Medicine, and especially to welcome you to Meliora Weekend. Many of you are celebrating reunions this weekend, and I hope you have a wonderful experience. I am proud to represent the School of Medicine as a student, as an SMD ambassador, and as a member of the Alumni Council. Two aspects I enjoy most about my experiences of School of Medicine and dentistry are the opportunity to conduct research and the collaborations that take place throughout the institution. And MedTalks exemplifies the best of both world-class research and amazing collaborations. Our first topic is automated tendon scar tissue identification using ultrasound and deep learning, presented by Dr. Alayna Loiselle and Constantinos Ketonis. Dr. Loiselle is an alum of the School of Medicine and an associate professor of the Department of Orthopedics and Rehabilitation, where her research program identifies novel strategies to improve tendon healing. Dr. Ketonis is an assistant professor in the Department of Orthopedics, specializing in the treatment of hand, wrist, elbow, and shoulder problems. After each topic, there will be an opportunity for a few questions, and we have some microphone runners in the audience that can help address those. And now, please help me welcome Dr. Loiselle and Dr. Ketonis.
All right. Good morning, everyone, and thank you, Umberto, for the introduction. So before we really jump into this, I wanted to kind of give you some background on both the projects, but also how this collaboration got started. And so, as you heard, my lab is really interested in the mechanisms of tendon repair. And regardless of the tendon, when you injure this tendon, these tendons heal with sort of a scar-mediated manner. It's very fibrotic, and it complicates healing in all of the tendons. But the flexor tendons, as shown here, right here in the palm of your hand, really have some special considerations and special challenges that we really need to consider. And so the tendons live within the synovial sheath here in your fingers, and it really allows the tendons to move in an almost frictionless manner so that you can have both gross and fine movements of your fingers. And because of this sort of snug fit between the tendon and the sheath, when you have this scar response, it really impairs the ability of the hand to move. And so, these special considerations are really what motivated a lot of the research in my lab. And when I met Dr. Ketonis, obviously this is a huge part of his clinical practice as a hand surgeon, but also his perspectives as a PhD trained scientist have really allowed us to develop a number of really exciting programs, I think. And so the one we're going to talk about today is sort of the most advanced of the collaborations we have. And the last point I want to make, people often ask me how these injuries happen, and I think what I'm going to share with you gives us some interesting insights into sort of how our society is changing a little bit. So when I first started talking about these injuries about 15 years ago as a PhD student here, one of the most common ways these tendons were injured was people trying to slice bagels and inadvertently cutting through their hands. But actually, in the last few years, the main culprit has changed, and it's actually avocados that are really a big hazard to hand health. So I just wanted to kind of give you that anecdote. As our food scene has shifted, so have some of the injuries that the clinicians are seeing.
Hi, so I wanted to start off by going over a clinical case, and this is one of my patients. And this is just to exemplify some of the challenges we see with repair of flexor tendons. And this is a very typical scenario. This is a 28-year-old male presented to the clinic after sustaining a laceration to his small finger. He was using a steak knife, not to cut avocados in this case, but still, nevertheless, he slipped and lacerated the volar aspect of his small finger. He went to the emergency room, got the laceration repaired, and presented to the clinic with inability to flex his small finger since the injury. Even though this is not his specific picture, this is exactly how they all look almost. There's a normal cascade of the normal fingers seen here, and the affected finger, in this case the small finger, is held in extension because the tendons that flex the finger are not connected anymore. So we took him to the operating room for a repair. I do this now all wide awake. The patient is fully awake. The affected finger is numbed up. We bring the tendon edges together and repair them using suture and a variety of different techniques. After the repair is completed, I ask the patient to move the finger to make sure that the repair is strong, the tendons are gliding, and that there's no impairment as far as catching of the tendon on any of the pulleys or any of the other structures in the finger. Now, repairing this injury is only half the battle. What happens next is what really defines the clinical outcome for the patient. Here's our patient on the my right hand side. 3 weeks out of his injury, and he is able to obtain half a fist, which is a great progress. His tendons seem to be gliding; they're not catching on anything, and he went on to have a great result. However, on the other side here, we do see patients that don't do as well. This is some patients will get a stiff finger, which does not glide. It stays straight and results in significant disability for the patient. And really, there's no good way to figure out who is going to end up being like this and who's going to go down the other route. Definitely, there's a number of factors that can contribute to that, such as the severity of the injury. If this is a crash injury versus a clean laceration, the soft tissues are involved. This will push you more towards a stiff finger. Surgical technique, of course, has a lot to do with it. But there's things that are out of our control, like the compliance with physical therapy and the patient's physiology. And it's really these last two factors that we're trying to, one, elucidate, and two, optimize with this project to try to push people from going from a result like that to a result like this. I'm not going to go through all the anatomy of the finger. This is just simply to show you that it's complex. Every finger has two tendons that are interweaved, and these are held down to the bone with a system of pulleys. And this complex anatomy and interplay of the sheath and the flexor tendons is vital for normal biomechanics. Any injury that might disrupt this fine balance can lead to adhesions and stiffness and disability. And unfortunately, we still see a significant number of unsatisfactory outcomes following flexor tendon repairs. Just to give you some numbers, just in the United States, there's 300,000 tendon repairs every year. This sums up to about $20 billion in cost, and actually the National Safety Council estimates that every flexor laceration ends up costing $70,000 if you sum up the medical costs, the lost wages, and the disability. As we talked about, the healing gets complicated by scar formation, which up to 40% of repairs ends up with range of motion limiting outcomes. Now, all these patients that get repaired, they do see physical therapy, and they're faced with a daunting task. One, you can move the patient fast, and if you do that, you might risk re-rupturing the tendon, or take it slow and go with delayed range of motion and physical therapy, which then pushes you more to lay down scar and have a stiff finger. So it's a really fine balance, and there's no real good way, as you'll see later, to fine-tune that. Despite our best efforts, a lot of these patients end up with second surgical procedures that are required to lyse the adhesions and get the tendons gliding again. And that's because currently there's no good biological therapies to improve the healing while reducing scars. So we're still relying on mechanical means, which means more surgical procedures.
Thanks. So it's really this clear unmet need in terms of biological therapies to improve healing that really motivates a lot of what we do in my lab. And so with the goal of kind of understanding this process better so that we could identify novel drugs or therapies to improve healing, we've developed a mouse model of flexor tendon healing, which is shown in this video here. And this model actually mimics a lot of the clinical scenario where the tendon's been completely transected, and then we go in and repair it with suture. And what you can see over here in these stained histological tissue images is that we have the two ends of the native tendon, but all of this is actually bridged by this scar tissue. And we're starting to get connections between the scar tissue and all of the underlying tissue, which, just like in the clinical scenario, is really going to impair the ability of the tendon to move, and also decreases the mechanical properties, making these tendons more likely to rupture if we're too aggressive with them. So this is a great model, but one of or two of the real limitations are that it's very very expensive to run these studies in an appropriate way to really understand the process or to screen biological therapies. And it's obviously also very time consuming. And so we were really motivated to kind of come up with a new way to more rapidly screen therapeutic candidates and to understand this process. And so we wanted to come up with some non-invasive ways. And it turns out that ultrasound imaging is actually a really ideal way to do this. So you can, ultrasound is safe, it's non-ionizing, it's relatively inexpensive to use. But what you can probably appreciate is that these images are pretty difficult to interpret on their own. And so we kind of took the strengths of using an animal model, and so again, we took these histology sections from the same animals we had conducted ultrasound on, and with this particular stain, we can actually identify the tendon pretty readily, as well as all the scar tissue, and so we were able to pretty easily and accurately identify the tendon and the scar tissue on histology, and it gave us a lot of confidence in what we were seeing on these ultrasound images. And so from there, we were able to sort of train the people in my lab to really accurately and pretty efficiently identify these tissues. And so we're able to do this in a three-dimensional fashion all the way through the width of the tendon repair site. And this ends up giving us scar tissue volume. And so what we found is that just by simply conducting an ultrasound scan of this healing tendon and quantifying scar tissue volume, we were able to much more efficiently identify changes in tendon function and range of motion, because as you have more scar tissue, your range of motion and tendon function decreases. And so this was a really big breakthrough, we think, in a couple of different ways. First, this is the only method to non-invasively assess tendon function in an animal model, which was quite exciting. But also, we now have a much more rapid and sort of high throughput way to potentially identify some promising therapeutic or drug candidates. And so we think that this is really going to sort of expedite our ability to both understand the process and to identify different therapies.
Now, I always had an interest in ultrasound, but when we first met, it became clear to me that this work has clear translation applications, not only for what Alayna has been working on as far as identifying biological targets, but as far as using ultrasound to give us the ability to non-invasively monitor healing progress in patients. This would allow tailoring the therapy to each patient's physiology and leading to true personalized treatment and personalized medicine. The current approach that we use during physical therapy is subjective currently and less data-driven. Basically, once the repair is done, we take the patient to physical therapy, and at that point, it becomes a black box. We don't really monitor what's going on underneath in the finger, but use the progress in therapy to manage the patient. Given that we don't have that information, therapy is typically generic, is not personalized, and we know that not all patients are the same. So we're looking for a more objective way to take a peek inside the finger in the repair site and see if there's gapping, if there's scar forming, if there's tendency to re-rupture, if we need to push these patients more, or does it need to go back to surgery for a re-repair. So when we started thinking about translating this to a clinical tool, it was clear that this has to be fast, it has to be reliable, it has to be user independent, and it cannot be laborious, just like we do in the lab. We have all the time in the world. Thinking about these limitations, it would be obviously very unpractical to train every single physical therapist or physician to become an expert ultrasonographer and expect them to be able to interpret what they're seeing on these ultrasound images. So we turn our attention to artificial intelligence, looking for solutions, and we ended up developing an artificial intelligence algorithm or deep learning to train and create an automatic segmentation model in a preclinical model, which was the mouse model. So the way this works, for those that don't know much about artificial intelligence, deep learning, which is what we use, is a subset of artificial intelligence. And we basically feed the algorithm pre-segmented images, so images just like that, where we tell it where the scar is. And this is done by the expert segmenter that's in the lab that's seen hundreds of these images. With every image that the algorithm sees, it learns how this looks until when hundreds or even thousands of images are fed into the system, it starts picking up the scar by itself. So it's like a baby learning over a period of time, but it's much faster than what you would expect with a baby. So once it learns, then the identification is really fast. It takes milliseconds to identify it once it's fully trained. This is how we went about it. These are the images that we fed it. The scar is segmented already. Then there's multiple ways to do this. Just very briefly, you can do it in 2 dimensions or 3 dimensions. Regardless of which method you use, you end up stacking these images to create a 3D mask, and which looks like this. And this is kind of an iterative process. As the machine is learning, it creates a 3-dimensional mask, which starts matching what is done by the human operator. The great thing about this is that with every set of training data that we give it, becomes better and better until the 2 masks become almost identical, meaning basically the machine learned from the best segmenter and now can do the same thing. So this allows not only rapid segmentation in the preclinical model, which is the mouse, but we can use something called transfer learning to start segmenting scar in the human. So given that even if we see the ultrasound images that are taken from humans, we don't even know what scar looks like in a human. Because we don't have the histology to match it like we have it in a mouse. So we train the machine on the mouse. We use transfer learning, which uses the machine uses the experience that it gained from finding scar in a mouse and starts extrapolating on what scar looks like in a human.
And so at this point, we actually had a pretty good deep learning or artificial intelligence model to automate the segmentation of scar in our mouse model, which is fantastic, and I think is really going to help us, like I said, identify some of these potential therapies much more rapidly. But there was a major hurdle when we thought about taking this into the clinic. And so in our preclinical animal model, we have a really nice setup where we can get images at a defined distance, and that really is critical for our 3D deep learning algorithms. Most clinical ultrasound probes are handheld, which really impairs our ability to get sort of reproducible and high-quality images, and we don't know sort of the distance between those images. And so the first thing we had to do was actually to build this jig that you can see here. And what this does is essentially allow us to get a 3D scan all the way along the length of the finger at a known distance between these images. And so this is really critical to ensuring that these images are of sufficient quality and reproducibility for our deep learning algorithm. And one of the key things is that we actually are collaborating with hand therapists on this, and so they're the people that are doing these ultrasound scans. So they're not trained ultrasonographers, and so we wanted to make this very easy to use. So this entire device and all of this data acquisition is just run from an iPad app, and so it's really allows almost anyone to be able to collect these images.
So we now have an IRB protocol that's approved, and we started collecting data from actual patients. This is an example from an actual patient. This is an ultrasound video. This is a patient that's 4 weeks out after repair of a small finger, laceration in zone 2, very similar to the patient we saw in the beginning. And here we, is it playing?
It's not playing.
Not playing. Maybe we can click on it. So we label some of the critical structures here. This is a proximal phalanx. This is a middle phalanx. This is the tendon, and if it was playing, you could see the tendon gliding back and forth. And then here is where we think a scar is starting to form that can have implications as far as the long-term function of this patient.
And so at this point, we were really confident that we could identify a scar, be able to see it on ultrasound, and so then we sort of moved forward to collect some of these 3-dimensional images. And we're really just getting this underway. But what you can appreciate in this video over here is that using this device I just showed you, we are able to collect an entire image stream, and we can look at this in all 3 dimensions, which really gives us important information into how the tendon is healing. And the goal is, like we mentioned, to take all these images, to train the machine so that we can go from these images that are somewhat difficult to interpret to actually having a real-time reconstruction of all of these different anatomical features so that we can see the relationship between the tendon and the scar, which is really going to be critical to provide clinicians sort of immediate feedback on how their patient is doing so that they can then inform the physical therapy.
So the overarching goal of this project really is exemplified in this images here. So it would work something like this. The patient comes in with a flexor tendon injury. He undergoes the surgical repair. Then during clinical visits and physical therapy, we use the automated ultrasound imaging system to collect three-dimensional images of the finger, which is then fed into the artificial intelligence model that can quantify and qualify the location of the scar and use predictive analytics as well as statistics to define a scar function relationship. So we can extrapolate based on the experience of the machine the final outcome of the patient. And that can also inform patient-specific management plan depending on how the scar or gapping of the tendon is progressing, which we hope that it will lead to improved outcomes in patients.
And so finally, we just really want to sort of highlight and reiterate that this was not just a collaboration between scientists and surgeons, but really required a unique set of multidisciplinary expertise. So like I said, we have buy-in from the entire hand surgery division, musculoskeletal research. We're also relying on our data science colleagues, particularly in the health lab, as well as engineers that designed and developed this device, and the hand therapists who have been a critical part of this. And we think that this sort of multidisciplinary expertise is critical to making this project successful, but also is a really unique feature of the sort of the collaborative expertise that we have here at the University of Rochester. So with that, we'd be happy to take any questions that you have.
Thank you. We have time for one question.
Sorry.
Okay, all right. This is actually superfluous for me. That's right. This is superfluous for me. But anyway, this slide, then the slide before, then the slide before that. Can you go to that?
Nope.
No.
Oh, I'm sorry.
But I can answer.
You can't?
We cannot.
Here.
Oh, maybe we can.
Very sorry.
No problem.
Well, we need some collaboration between data science and engineering.
We got it done.
And, let's collaborate, what the hell? Okay, there was one picture that has multicolors.
Yes.
Great, advances in technology.
This one or the next?
The next one, this one.
That one.
Yeah,
Yes.
yep.
Thanks for the collaboration, guys. The red, I assume, is scar.
The red is the scar, yeah.
See, that next slide, it's there, but I can barely see it. It said scar tissue.
Yes.
Sorry.
It's there.
So I had to extrapolate.
Yes, it is
And
there.
that's normal intelligence. That's not artificial.
Yes.
Nothing artificial about this. But very nice presentation.
Thank you.
Dr. Loiselle will actually be at the alumni happy hour.
Yes, we'll both be there.
Oh, perfect. Excellent.
Yes.
So you'll have another opportunity to ask questions.